Hello and welcome to today's live Coffee Talk CME webinar entitled Applying Trauma-Informed Care and Harm Reduction Principles to Optimize HIV/HCV Care for PEH. This activity is supported by independent educational grants from AbbVie, Gilead Sciences, and ViiV Healthcare, and is jointly provided by Global Education Group and Integritas Communications. Let's turn things over to our presenters, Dr. Stacy Truskin and Ms. Juliana Wallace. Enjoy the program.
Good day, everybody. I'm Stacy Truskin, and thank you for joining us for a webinar, Applying Trauma-Informed Care and Harm Reduction Principles to Optimize HIV and Hepatitis C Care for People Experiencing Homelessness. And our learning objectives today are going to be to discuss the risks of HIV and hepatitis C virus among people experiencing homelessness, to identify key principles of harm reduction to be incorporated into HIV and hepatitis C prevention and treatment, and to incorporate trauma-informed care to optimize HIV and hepatitis C care among people experiencing homelessness. All right, let's move on to the epidemiology of people experiencing homelessness with HIV, but first, reviewing the social determinants of health. Let's talk about some of the non-medical factors that affect health outcomes. Things like unemployment, unstable housing, food insecurity, education, income, access to healthcare, and of course, stigma and discrimination all impact health outcomes. And these also can include early life experiences and trauma. So all of these things together can impact someone's overall health, their engagement in the normal healthcare structure as well. And there's a quote here that I just want to share with you all. Until a healthcare problem becomes life-threatening, somebody who's experiencing homelessness may likely choose shelter or food before going to a provider. These priorities always must be considered when dealing with the homeless population. What might at first seem like carelessness or non-compliance, in reality is simply a struggle to survive. And I think those of us that care for people who are experiencing homelessness, there is a hierarchy of survival. And as providers, the agenda or the to-do list that we may have for our patients, the priorities, may not be the same that the patient has for themselves. And really beginning to understand what is important to the patient, what is that hierarchy of need and survival, that is the ability then to unlock sort of the engagement in healthcare. And you can begin then eventually to work through your problem list as well as a provider once you address the needs that the patient may have. Moving on to the epidemiology of HIV among people experiencing homelessness. There in 2017, 9.1% of people with HIV were experiencing homelessness. And those individuals were more likely to be Black or brown, transgender, and also have a substance use disorder diagnosis. The rate of diagnosis of HIV is higher among people experiencing homelessness. Yet, people experiencing homelessness have about a 50% lower chance of achieving HIV viral suppression versus those with stable housing. And there have been studies that have showed that viral load is linked to the degree of housing stability. And in the graph on this slide, you can see that in the early 2000s, there was a decrease in the rates of HIV among individuals counted as homeless in the US, but more recently from 2016 on, we've started to see an increase in those numbers. Let's turn our attention now to hepatitis C. The estimates of HCV among people experiencing homelessness range from as low as 10% in the literature all the way up to 52% versus a 1.3% estimate in the general population. So there is a significant disparity there. Studies have shown a low baseline knowledge about hepatitis C among people experiencing homelessness, and there are multiple risk factors that have been identified in the literature, such as injection drug use, and then collinear factors such as mental health comorbidities and a history of incarceration. Only 42% of people experiencing homelessness testing positive were treated in a San Francisco study, further exacerbating the transmission rate. So if we think about treatment and cure of hepatitis C, really treatment is prevention, right? You can't transmit something you yourself do not have. And so it is critical not only for the individual to be treated for hepatitis C so they can avoid the long-term sequelae of hepatitis C like cirrhosis or liver cancer, but it is also important for the community to treat every individual for hepatitis C because you can prevent transmission. So treatment really is prevention, and addressing hepatitis C in a population who experiences homelessness is really critical. Exploring trauma faced by people experiencing homelessness is important. Trauma is defined as an event experienced by a person that leaves a significant negative effect, may be due to a combination of adverse childhood experiences, race or ethnicity, sexual orientation, mental health comorbidities, and homelessness. And the rates of trauma among women experiencing homelessness were as high as 76, all the way up to 100%, and also high for individuals who identify as male, 67%. And there were also higher rates of trauma in people with HIV. I think it's important to recognize that people who experience homelessness can face stigma and further trauma in healthcare settings. We like to think of healthcare as a place where folks receive support, receive healthcare that contributes to a betterment of their health status, but healthcare itself can be a source of trauma for individuals. And here's a little quote that really encapsulates the story of one individual and how healthcare furthered her trauma. So this individual had suffered a brutal rape. She was a woman in her late 40s. She had lived on the street throughout her whole life, back and forth. And she was telling us her story. She needed to share it. And when she told it, she didn't cry. She only wept when she talked about how she was treated at the hospital because she was bleeding so profusely, and she flinched at a needle that the nurse was trying to give her. And the comment from the nurse made to her was, "Well, look at your arms," as if you have a problem with needles. And that weighed so heavily on her. And that is when this woman broke down. And I think that's a good example of how trauma can be inflicted by the healthcare system itself. Next slide, please. So with that, I'd like to bring in my colleague, Juliana Wallace, to have a little discussion with me about how does a baseline understanding of trauma experienced by people who are experiencing homelessness improve care.
Thank you, Stacey.
Sure.
When I think of this question, what comes to mind for me is all of us in the medical setting having a commitment to understand the pervasive nature of trauma for people experiencing homelessness. When I read this, I don't necessarily think that I need to hear that person's in-depth story, but more that I am seeking out an understanding of the traumatic experiences, both of homelessness, of active substance use, of witnessing violence on the streets. And I have that in mind as a lens that I use when I'm practicing medical social work or medical care in a system.
Yeah, I think that's really critical. I think understanding what somebody experienced before they walked in the door, whether it be seconds before or years before, helps really deliver more effective care in a healthcare setting. It's a critical piece. All right. So Juliana, I'm going to turn it over to you to take a deeper dive into trauma-informed care.
Thank you. So the definition that you see here is actually my working definition right now as a trauma-informed clinician myself, that I feel like is a never-ending piece of work. So I don't know that there's a finish line in our trauma-informed practice. There's only continuous learning and exploration. I'm not going to read this definition, but I would like to point out a few things that I think are important in grounding us in what this word means, because we're using it and seeing it a lot. Trauma-informed care is an organizational framework. So I'm intentionally saying here that this isn't just about how us as a clinician work with and treat our clients, but it's also in the way that the organization interacts with the staff and the community. It's grounded in strengths of all of those systems. So in my practical application of this, the individuals I'm serving, say when I go out with our Portland-based street medicine crew, right? I'm seeking the strengths of the individual clients who I encounter. I'm also seeking to find some strengths in the system in which we serve. So sometimes I'm building a bridge back to the hospitals by talking about what hospital systems can do, and also the strengths of the community. I think it's really important to talk about safety. And when I was hearing Stacy read that vignette, of course, I had a lot of sadness in my heart for that woman's experience. It's also a common story that I hear when I'm doing medicine in camps, homeless medicine in camps, that the emotional safety that's experienced in our medical systems is often lacking. And the physical and emotional safety is actually, a 360-degree experience. How do our staff feel safe? How do we feel safe? How do we know how to talk about when we feel safe and when we don't, in a transparent and respectful way? This last piece is important to me, and it's my attempt to weave in racial inequities and institutional oppression. Trauma-informed care is a commitment to stop and examine the way things were done in the name of seeking the systemic nature of oppression and trying on a new way of doing things. And we do that through hearing the voices of those involved. You'll find many definitions of trauma-informed care, and I think for each of us, it's an opportunity for us to take, what does trauma-informed care look like for me? What pieces or threads of the principles are coming out in my practice right now? So I encourage you to write your own short definition if someone were to ask you, what does trauma-informed care look like actually in your practice? SAMHSA has these kind of wonderful pathways of how we talk about trauma-informed care, and I'm just going to touch briefly on each of them. I do encourage you to follow the link at the bottom and read this entire publication. They've done a really nice job of the concepts in general of a trauma-informed care framework. So the 3 E's of trauma, and I'm going to ground this in people experiencing homelessness, accessing medical care. And the 3 E's of trauma would be an event that people experience. Let's take our vignette. The event, there were 2 events that I heard in there, right? She had a traumatic sexual assault, and the other event was the emotional trauma she experienced, the event she experienced of hearing the nurse say that to her. We all have different experiences of the events. It was interesting in that vignette to hear that, like, the experience she had sharing her story of the sexual assault and the apparent effects were not a tearful explanation, just a fact explaining the story. Yet the event of the nurse, she experienced great emotional distress, and the effects of that were a deep sadness. The 3 E's of trauma can be applied to many things. I encourage teams and individuals to become familiar and use the 3 E's of trauma to help understand events that you've experienced, such as the COVID pandemic, the array of experiences we each have to that, and the lasting or short-term effects of that. The 4 R's go something like this. It's realizing the widespread impact of trauma for people experiencing homelessness. It's recognizing behaviors as a root experience of that trauma. And it's responding in a way that resists re-traumatization. And I actually think it's really key to not get too stuck on we will never re-traumatize people, because resisting re-traumatization is being aware of potential triggers, some of which happen by accident. It can be a name that we have, a word that we use, a way that we say something, a phrase can trigger or re-traumatize people. So resisting is really important to me because it's about being aware and in tune. The 6 key principles are really, I would say, the core of when we think about how to apply trauma-informed care to our work. Utmost importance being safety, which I talked about in my definition. I really think it's critical that we practice transparency. What this might look like is when you see a patient, what are some questions you might then later staff or ask with a colleague that you were hesitant or scared to ask to the client themselves, the patient themselves? And to me, that's an opportunity. My transparency flag goes up and I say, I wonder if I had an opportunity to practice a respectful and collaborative question experience with the patient to be more transparent in what I was thinking, what I was considering. I think about substance use as a common thing that when I worked in the acute care hospital systems, I was surprised when I first came at the amount of conversations we would have, let's say in the hallway or in the charting stations. And I'm like, well, let's go in and talk to the client, right? If we're worried that they might be actively using, let's ask them about that. Those are our opportunities to practice increased transparency that grounds us in a principle of trauma-informed care. Peer support is emerging best practice and model in many settings of hearing and working with and leading people who have lived experience in substance use, homelessness, mental health, the most common ones, but also in just navigating our medical health systems. This is both in hiring and advocating for peer support to be on our medical teams, but also to be finding ways to listen to the voices of the consumer. I'm going to skip down to choice. I think this is another opportunity like transparency. If I were to pull a principle forward, choice gives empowerment. So anytime we have an option for someone, and I usually encourage people from a practical perspective to provide 1 to 2 to 3 options and choices, not 7, and make sure that the choices are realistic. Is now a good time to draw that blood? Would you like to come back tomorrow? Is now an okay time for us to talk about this? Would you like to bring someone with you to support the conversation? And the 10 implementation domains we're not going to touch on today, but I think it's important to get a view from an organizational perspective or a system perspective, what SAMHSA says it would take to truly be engaged in implementing trauma-informed care at a system level. I wanted to focus a little bit today on an application of trauma-informed care around language. I actually took this picture in a medical setting where we are serving a high proportion of people experiencing homelessness with comorbid medical, substance use, and mental health issues. And this was actually posted by our peer support team after listening to the way that the staff were talking about clients. And it brought me to tears. I took a picture of it. And I went and asked them, I give a lot of trainings and talks on trauma-informed care, and I really want to bring this story to life of this language is powerful. And in many ways, it doesn't just describe reality that we're seeing, it creates the reality it describes. And this was an ask for us to be mindful about how we talk about people who are experiencing such barriers and systemic oppression. Here's some ways that we can do that. Person first language. This is, to me, a really simple and applicable practice that we can all try on and take some time to change our language, right? I think of myself when I'm learning Spanish on my really fun app, right? I think it's Duolingo. And it takes me time and practice and daily kind of correction and repetitiveness to change my language. So I put this slide up here and say it's easy, but for some of us, we catch ourselves describing people in not a person first way. So you might hear that addict. I would try on a person with a substance use disorder. I sometimes take this a step further and say a person who's using substances in a pattern that isn't working for their life. Right? That homeless guy over there, or this homeless guy that keeps showing up every day in our lobby, it's actually a person who's experiencing homelessness or houselessness. I might even try on a person who's living outside to actually describe the experience of where they're living. Oh, they're insane. That's actually a pretty common one, or they're crazy. I encourage us to hone in on what might be happening and describe it. A person who's having an intense and scary experience. And we could go, there's a number of examples for this. And I do encourage you, if this is of interest to you, to learn more about person first language. A practical example of how I've seen this in my practice, I had the pleasure and honor to work alongside a Nora Englander, who's pictured here. Her and I launched an addiction consult service in an acute medical setting in Portland. And we brought the first peer support staff ever hired at the hospital, formally from a substance use and homeless perspective. And she shared with me, and I have her permission to share this in my presentations. This is what's at the end of her signature and every medical note she writes. And I just really love it. It's a message to us as providers that using clinically accurate and medical appropriate language matters when talking with and documenting about people experiencing homelessness or individuals who have a substance use disorder. The reason is because there's stigma and stereotypes that are faced, and we perpetuate them in our writing and our language. There we go. She actually has a usable link that will bring us here to the NIDA recommendations around substituting appropriate language in substance use disorder. So I picked 3 of these that I thought were most appropriate for this, grounded us in this conversation. And I will tell you that sometimes having conversations about instead of and trying to use and the reason why, like it looks neat and awesome on this slide. And it is actually can be really uncomfortable when we have these conversations together, because I would imagine myself, when I went to graduate school, I went into social work to help and heal. And I would imagine, Stacy, you also went to medical school to help and heal. And when we have to examine the language we've been using and hear its negative impacts, it can be challenging for us. And this is the work of trauma-informed care, applied, in my opinion, to just be willing to stop and examine this, right? This is that last part of the definition of the way things were done for a different way of doing it. So instead of saying someone's clean, we talk really clearly about toxology screen results are testing negative, or being in remission, or not currently or actively using drugs. And I usually find when it comes to language, it's actually just 1 or 2 more words that take us out of a judgmental or potentially stigmatizing language and into a more, I would just say, a more rich explanation. Dirty, when we use this all the time, their pee was dirty, there was, but this is, when you think about it for a minute, how impactful that language can just be, and how it also can influence someone coming in. Especially, I love electronic health records and how far we've come. And this language is so important because what we read continues on lives on in people's chart in medical care. And then abuse, you heard me earlier offering in the person first language, using substance use disorder, using the word misuse instead of abuse, and just using the fact that someone is using a drug. And then they give us some, because I call this calling out the why. And then there's also when we dive a little bit deeper, if we had time to go into the neurobiology of trauma and how that supports trauma-informed care. We can also just talk about how the impacts of language and experience then actually affect our brain and behavior. I don't think I could talk about application of trauma-informed care without talking about taking care of ourselves. Being someone who's entering my 20th year in the intersection of homelessness and behavioral health here in Portland, Oregon, being in touch with what brings me joy and paying attention to the self-care is what keeps me grounded in this work. It's what helps me have self-reflection so that I can kind of pay attention to the systemic nature of oppression and racism and trauma, especially in the medical system that Stacey talked about, so that I can help undo that work. Like, my work alone is hard enough. All of your work is hard enough. So sometimes it feels like we're adding something on. And I think that's unavoidable. We are asking to do something different in a different way. The outcome is just so profound and clear to me in the way that people who experience homelessness respond to some of these principles and application in such a positive way, increases their engagement in our work and which brings us greater satisfaction, given we all came to help and heal. So I just offered a couple things. The ProQual is a great kind of measure that we can use to help us understand the positive and negative impacts of working in a high stress and sometimes highly traumatic environment. And then I actually really love, from a social work perspective, the self-care assessment. This is just a really nice way. I take this, once a year to just inventory for me. How am I prioritizing and taking care of myself so I can show up as the best version of Juliana for the clients and the teams in which I work with? I hope that something that I shared today intrigues you to learn more. I wanted to offer just a few books that I pick and choose from that might be helpful. I have the honor and privilege to work with psychiatrist Dr. Phil Shapiro, wrote a wonderful book called Healing Power, Physician Heal Thyself, which is really grounded in our own work around healing qualities and understanding kind of the dynamic nature of suffering. My Grandmother's Hands is the current textbook that I use when I teach trauma-informed care at the Graduate School of Social Work. This is a interactive mindfulness and educational book about understanding how white supremacy and racism live inside our bodies. Trauma Stewardship is a wonderful guide written by a social worker who does high crisis environment work. And I have actually seen her talk live. She has if you check out her website, she's actually doing some pretty incredible work. And her newest book is called The Age of Overwhelm, which I'm not done reading. The Realm of Hungry Ghosts, Dr. Gabor Mate is just one of my heroes and inspiration in the work. He's a palliative care doc and addiction medicine physician. That book is really about the connection of homelessness, addiction, and trauma. Nadine Burke talks about adverse experiences in childhood and how that impacts our health outcomes. And then, of course, The Body Keeps the Score, about understanding the long-term impacts of trauma in our body. And I think that's it. That brings us to our next question. Stacey, how have you employed trauma-informed care principles in your practice when working with people experiencing homelessness?
Yeah, thank you so much, Juliana. That was a great overview of, I know, a topic that is very broad and very deep, and proper trainings can take hours. And so this question of how have we employed trauma-informed care in our practice, I think we really try hard as a practice to utilize person-first language. We take care of a lot of people who inject drugs. And so instead of using that language of injection drug user, we really focus on it's a person who happens to inject drugs at this moment in time, recognizing that these things are transient and that folks can dip in and out of situations, and that doesn't define who they are as a human. It's something that they're experiencing in that moment. So we try hard to use that language. I think the other thing that comes up often in clinical practices that serve individuals that have experienced a great deal of trauma is that when things may go a little bit sideways for them or don't meet their expectations or have unexpected, unintentional experiences. So let's say somebody comes in late because they've lost their bus pass, or it took them a long time to get in, and they've arrived, an hour and a half, 2 hours late, and the provider may or may not be able to see them, delivering that news in a trauma-informed way, recognizing that because that individual may have experienced stress prior to coming in, or even historical stress, that the tools that they may be able to utilize in that moment to manage that disappointment or frustration may not be there 100%. So how can we as a practice help de-escalate that moment and approach them in a trauma-informed way that doesn't then further compound the issue and result in like an escalated situation in the waiting room? And so I think recognizing that everybody brings with them experiences and adjusting our interactions in informed ways is critical to the work that we do. All right, I want to move us on to a look at harm reduction. And so this is a quote from Dan Bigg, who was the director and co-founder of the Chicago Recovery Alliance. And I love the way that he describes harm reduction, which is any positive change as defined by the person at risk for harm. It's really meeting people where they are and providing the tools and information they need to keep themselves and those around them healthy. So the tenets of harm reduction are to really provide non-judgmental care, to do your part in fighting discrimination. It doesn't require abstinence, but it's not against abstinence, and it does not attempt to minimize or ignore real harm and danger that could be associated with drug use. The foundation of harm reduction identifies and acknowledges the risk of itself that you're discussing, whether that be drug use or sex work. It brings the mindset to the situation, including somebody's thoughts, moods, expectations, both parties that are engaged in that conversation. And it also acknowledges the physical and social environments of where the person is and their perception of how that can either promote or reduce risk. It's also important to acknowledge that harm reduction can go beyond preventing HIV and viral hepatitis. It can prevent drug overdose. It can prevent bacterial complications of injection drug use. It can prevent further trauma or further violence that an individual may experience. But it really needs to be defined as harm broadly. So how can we as medical providers reduce the harm that somebody may experience given situations they find themselves in? And it involves providing information, education, counseling, outreach. It may or may not involve providing medication for opioid use disorder, depending on what somebody is open to engaging in at that moment. It may or may not involve syringe service programs as a form of harm reduction, or combined mental health services involving some combination of all of those things. It can often involve prevention of injection-related wounds. And so something that I do in my practice when I see a person who happens to be injecting drugs is I will give them some alcohol swabs if they're not ready to stop injecting, and teach them how to clean their skin appropriately to avoid cellulitis or other bacterial complications of injection drug use, like endocarditis. Cotton fever is something also that you can educate patients about. For those of you who may not know, little bits of cotton may or may not be used at the tip of a needle as a sieve to take out the particulate matter that may exist after somebody has combined the drugs with a solvent, a liquid solvent. And so you want to avoid injecting particles or impurities into the bloodstream. And so cotton is often used at the tip of the needle to be that sieve. And oftentimes folks will take that injection drug use equipment, including the cotton, and may store it for use in the future. And if you store wet cotton in a warm, humid environment, it can create opportunity for bacteria to breed, and then reusing that can result in something that somebody may refer to as cotton fever, which is really a transient bacteremia. And so educating folks about not doing that and the risks associated with it, and even providing alternatives to doing that to keep somebody safe or reducing the harm could be part of harm reduction. Overdose prevention and response response, teaching individuals how to utilize naloxone for others and keeping it on yourself. And if you happen to be injecting with someone, making sure they know where it is and how to utilize it so that you can prevent overdose for yourself or others. Safer injection technique may be part of harm reduction, and talking to patients if they're not ready to stop injecting, how to inject more safely. Alternatives to injecting. If somebody has utilized all of their veins or are unable to access them, what are some safer alternatives to injecting in the neck or in the groin, and avoiding utilization of big arteries that could cause problems in the future, big veins. Immunization is a part of harm reduction. It involves making sure that folks are protected against hepatitis B and hepatitis A and pneumococcus and tetanus and other things. Making sure that you're identifying sexually transmitted infections to reduce harm to that individual and also to others through sexual transmission. Making sure that folks have access to safer sex supplies like condoms and other things. Giving individuals access to case management to help them with things like housing and food are also ways to reduce harm. And substance use disorder treatment, should an individual be ready for that, as well as employment assistance. And I think it's really critical to recognize that we all utilize harm reduction in our everyday lives. Many of us will speed, for example, and not go the speed limit. And that recognizing that is dangerous behavior for ourselves and potentially others. But many of us, if we're running late, may not be willing to say, oh, I'm never going to speed again. But we put on our seatbelt every time we get in the car. At least I hope we do, because that is a form of harm reduction. God forbid anybody get into an accident, that seatbelt can potentially save your life. What is harm reduction not? It's not an approach of whatever happens, happens. It's not anything goes. And it's not always just simply meeting the client where they are, but it involves the other pieces of it, the education, the back and forth discussion, assessing where somebody may be in their thinking and in their readiness and what they're willing to accept. And it's not just helping a person who's gotten off drugs to, you're not helping them start using again. And it's not condoning, endorsing, or encouraging. It really is just acknowledging that this person is where they are, that they are engaging in any sort of activity or environment that may put them at risk, and helping them to understand how they may be able to keep themselves safer. So, Juliana, are there specific harm reduction considerations that you find that are unique to people experiencing homelessness that you can share with us?
Great question, Stacey. Things that come to mind, hygiene kits, handing out hygiene kits, both on-street outreach work and in clinic settings. So having on hand things that can specifically help people, in my opinion, with wound care, considering you might not have access to running water. So more bottled water, not being, as much as we can offer people so that they have clean water, and then all of those wound care supplies. So we actually make wound care kits as a harm reduction approach to spread of infection. That's what comes to mind for me.
Yeah, those are great. Those are great suggestions, great options. I think there are harm reduction practices that can happen at the provider-patient interface, and it involves really establishing trust and two-way communication. You want to have it be a conversation and not a lecture with your patients. You want to make sure that the patient does not walk away feeling stigmatized or judged, but really listened to and accepted. Providing feedback on HIV and hepatitis C risk factors once you get from a patient how they're using drugs or what they're engaging in, what environment they're living in, all of those kinds of things. Giving them some feedback and having a conversation, a two-way conversation around that. Providing education and support around the possibility of hepatitis reinfection and how to prevent it is critical. Making sure that your patients know that it's not just a about sharing the syringe, but it's about maybe sharing the water that may be used to prepare an injection, or sharing cookers or other drug use equipment. But the syringe itself is not the only thing that can transmit hepatitis C or HIV. You want to support risk reduction efforts and monitor behavioral adherence in non-judgmental manners, and provide practical hands-on harm reduction and assistance. And that means knowing what resources are available in the community to offer to your patients, such as syringe service contact information, locations. You may actually want to even prescribe syringes to patients. We do it with our diabetic patients all the time. We may prescribe blood pressure cuffs to our patients who have hypertension, and prescribing clean syringes to patients who are injecting is another way to keep them safe. You want to make sure you're treating either sexual or individuals who happen to inject drugs with your patient all at the same time, to prevent transmission back and forth of sexually transmitted infections, viral hepatitis, HIV, etc. And if a patient is at a space in their life where they're interested in receiving medication for opioid use disorders, you want to be able to refer them or prescribe buprenorphine yourself if you have your X waiver. So a quick word about medication for opioid use disorder. It's also known as medication-assisted treatment. It can be used with methadone, buprenorphine, naltrexone, or single tablet buprenorphine, naloxone. It's been safe and effective in suppressing illicit opioid use, and it improves physical and mental well-being in many scientific studies. And it also has been shown to improve adherence to hepatitis C therapy. Data has shown that retention in MOUD programs shows substantial reductions in the risk for overdose mortality, as well as all-cause mortality. And just a quick overview for those of you who may not be as familiar, buprenorphine is a partial opioid agonist. It's a mono product, and it can be used also in combination with naltrexone. Naltrexone is an opioid antagonist. It comes in both oral and injectable forms, and methadone is a full opioid agonist. And some models of care could implement either directly observed therapy or modified directly observed therapy, but you want to make sure if you're using those things, it's not in a punitive way or in a mistrustful way, but in collaboration with patients so that they feel part of that decision-making process. The benefits of harm reduction have been shown in studies. There have been 50% reduction in hepatitis C transmission in individuals who are engaged in medication for opioid use disorder, and a 23% reduction in HCV transmission with syringe service programs overall. And Europe has done an extraordinary job globally around syringe service program access, with studies indicating a 56% reduction in hepatitis C treatment, and a study that looked at various models of MOUD care delivery, so both through directly observed treatment, group therapy, and individual treatment, showed high SVR12 weights, which stands for sustained virologic response at 12 weeks post-treatment, which is another fancy way of saying cure. So irrespective of how an individual was receiving their MOUD and their Hep C treatment, they were able to cure at greater than 90%, irrespective of overall adherence. So it just shows that MOUD treatment really, really works to support people going through hepatitis C treatment. So Juliana, again, I want to pull you in here. What examples of harm reduction success do you have from your clinic that you can share with the audience?
Yeah, well, one thing that comes to mind is under our pharmacy and primary care team, we set up outreach tents in the parks around our clinic to support Hep C treatment, enrollment, and testing, and provided some incentives, handouts, but really went to where people were. And if they weren't ready to come into the clinic, engage in that treatment, being just outside in their space was a really great kind of approach and technique to engaging folks.
That's great. Thank you so much. I think that's a wonderful example. I want to make sure everyone leaves this webinar understanding some resources that you can utilize to locate those resources for harm reduction in your community. You want to look for syringe service, or otherwise sometimes called needle exchange programs, naloxone distribution locations, MOUD clinics, and local recovery alliances. There is a syringe service program locator you can see on this slide, which can be downloaded or printed out. There are resources at the bottom of the slide that you can use for that, as well as naloxone locators. So in conclusion, I just want to remind everyone that people experiencing homelessness have a higher risk for HIV and Hep C compared with those with stable housing. Employing principles of trauma-informed care can improve interactions with all patients, including those experiencing homelessness. And person-first language can really shift the focus to the patient and is more affirming. Harm reduction can go beyond preventing HIV and hepatitis C, and really critical to utilize those resources for harm reduction in your community. So please do get familiar with those. Okay, so we have a couple of questions that have already come in. Let me just pull those up in the chat. So the first one, Juliana, I'm gonna open this up for you. What would be an appropriate trauma-informed care way to address when a client uses words like clean to describe themselves or others?
That's a great question. My approach there is to let people are empowered to describe themselves in any way that they choose. I wouldn't join in their language. So I would use my own intentional language, especially as someone who does not have lived experience in like injection drug use and recovery cycles. And so I'm really just cautious that it's my intention to use different words, and they are welcome to use words that work for them. This same question comes up sometimes with hate speech, and there is a different response there, that if we have language that moves from just judgmental language into hate speech, regardless of whether you're a patient or a staff, we just don't have some of those words in our spaces to keep the space safe.
I think that's a really critical distinction to make, particularly in today's day and age. So there are a few questions here really inquiring about the street team that you mentioned, the group of folks that go out and take care of folks outside of the health center. Can you share the question is specifically the professional makeup of your street team?
That's a great question. So at the organizational level at Central City Concern, our street team only consists of community health workers. The street work that I referenced when I'm a medical social worker is with Portland Street Medicine, where I'm a longstanding volunteer. That team is comprised of LMP. I use that language, a licensed medical professional, to describe a doctor or physician or PA, basically a medical professional that has the ability to prescribe medication. Then we have a role that's either a nurse or an EMT. So we have a social service worker who's usually a social worker. And if we're really lucky, we have a scribe. And that team goes out and provides street-based care 4 days a week.
That's excellent. Thank you for that. And then the next question is, do you have specific suggestions for raising awareness of trauma without risking re-traumatization?
I read in this, do we screen for trauma or not screen for trauma? And we know that you will often bump up against regulatory requirements that actually ask you to screen for trauma. And if you do, I encourage just scripting and training around how to ask those questions. I often say, I'm going to ask you a couple questions about some experiences you may have had. This is not the space, and you do not need to go into detail, but I'm getting at, do you consider yourself a survivor of trauma? Mm-hmm. Right? So I'm actually like setting limits that's if we don't have the time, space, and training to unpack traumatic experiences, I'm kind of creating some boundaries there. And then I'm also kind of concurrently moving to survivor-based language, right? That you have survived and implies innate resiliency in your traumatic experiences. like from everything I've learned and where I am in my career, I'm more of a fan of a universal precautions approach to trauma-informed care, meaning I would assume that everybody has survived adversity and trauma in their life, and that trauma-informed interventions can do nothing but help and support any human. And so reducing screening questions, especially at the front end and or not with someone they're going to have a long-term relationship for, i.e. like medical assistants are often the ones asking actually really intense trauma-related questions, just given their role and workflow and the flow of a clinic, yet have some of the least amount of training and support, and then what to do with the content that comes out.
That's great. I think we have time for one last question, then we have to get to our follow-up questions for the audience. We've had the question is, we've had good experience with harm reduction hygiene kits. So have we in our clinic. Do you, Juliana, have a system for distributing hygiene products to people who don't come to a clinic? And it sounds like you're doing a lot of this in your outreach work as well.
Yeah, we're just lucky to have a city and county infrastructure here in our region that funds and supports community health outreach workers. And so we are able to do that through that arm of our clinic work. And the goal of that team, they are all actually signing people up for our state Medicaid and connecting them to either our primary care clinic or a clinic of their choice, sometimes camp location dependent. So that's how we're able to do that for our non-clinic based folks.
That's great. Thanks so much, Juliana, for those questions. But I really want to take the last minute to thank Juliana. Thank you for being here today and sharing your wisdom around trauma-informed care. And I want to thank all of you for taking the time to be with us today and to really learn about these two critical topics and how we can all make the healthcare experience for people who experience homelessness a little bit better. So thank you, everybody.